technology, cables are not loose or anything?
Yeah.
We're ready? Okay, great. Well, so let's get started. I want to welcome everybody. My name is Roger Hartle. I'll be moderating tonight. I'm a member of the Explorer Club. I'm also a neurosurgeon here at Weill Cornell New York Presbyterian Hospital. And when Ann Pastor, she asked me if I wanted to take the special occasion of Valentine's Day to talk about the most iconic organ in the human body. I thought we were going to talk about the brain or the spine. I said, no, I want you to moderate a session about the heart. So I had to look up in the dictionary again, the heart. So how many beats a day? Does anybody know how many beats how many heartbeats per day? Any guesses? Now, 115,000, right? Is that correct? 115,000. 2 gallons of blood every day through 60,000 miles of blood vessels. That's what the heart does. And if something goes wrong, obviously, that is a big problem. It's the most vital organ that we have. Medicine has evolved and surgery has evolved tremendously. And I think as an explorer, it only makes sense to really consider that some of the major achievements of human exploration is really, some of the surgical miracles that are being performed now, not only heart surgery, neurosurgery, and all types of surgical subspecialties, but especially heart. And so I was able to get some really excellent speakers for tonight that I'll introduce. And the immediate, really, impetus for this presentation was obviously this recent event only 5 or 6 weeks ago in Maryland, a tremendously important surgery in Maryland that took place, where a patient who had end-stage cardiac disease received the heart of a pig, which is quite, if you think about it, quite crazy. There's a long history, and I think one of our speakers, Professor Naka, is going to talk to us a little bit more about that. But we'll talk about that. We'll talk about some of the ethical dilemmas. There was the baby Faye in the 1980s that you probably heard about. That was a tremendously sad story that took place. Heart-lung machines, something that we've, in the hospital now, we've been dealing with for the last 2 years increasingly, because patients with COVID may have end-stage, pulmonary disease and then being treated with, ECMO, with the extracorporeal circulation. Maybe we'll talk about that as well. But I'm excited that we're going to be taken on a journey through the history and the exciting developments of heart transplant surgery. And we'll have all the way on the left Professor Naka. He's a professor at Weill Cornell. He's a cardiothoracic, a heart transplant surgeon, originally trained in Osaka in Japan, subspecialty then at Columbia, and he runs the cardiac transplant program at Cornell and New York Presbyterian. And that is actually the largest volume heart transplant program in the country, believe it or not. I didn't know that, so it made me very proud to be part of that organization. He'll talk about the history of heart transplant surgery and give you a lot of information. And then we'll have Dr. David Majur, who is a cardiologist who specializes on intensive care medicine, and he's going to talk about some of the genetic manipulation and the immunosuppression that is necessary to make these types of xenotransplant surgeries really successful. He trained at Hopkins and UCSF. So we'll talk to 2 currently practicing surgeons about what we do right now and what we'll do in the future. And then we'll transition and have Professor Hussein, who's going to call in from Ohio, from Toledo. Professor Hussein is a cardiothoracic surgeon originally from Peshawar, from Pakistan. He's a member of the Explorer Club. He gave a presentation a few years ago. He actually explored the Indus River from its origins all the way to its, to the sea. I haven't had a chance to listen to that, but I heard it was a wonderful presentation. So, but he's also a cardiothoracic surgeon. He's retired now. He's going to talk about some of the ethical considerations and dilemmas related to heart transplant surgery. And then finally, we'll have a gentleman here, Mr. Sheldon Silber, who's going to call in from La Jolla. He's actually a heart transplant patient who received a heart-lung transplant 33 years ago. He's just about to turn 66 years old. So he's lived half his life with a heart-lung transplant and then even a kidney transplant on top of that that was required because of the medical side effects of the medication that he was on to immunosuppress the heart and the lung transplant. So that's the program for tonight. And I'm a member of the club. I have an exhibition coming up at the Grolier Club. If you're interested in mountain photography and desert exploration, the exhibition opens on March 4th or March 2nd, I think. It's going to be running for 2 months at the Grolier Club. And I just want to put in that little plug and ask me to do that. Otherwise, I would never do that. So thank you so much. And we're going to start out with a humorous comment by Winston Churchill. I'm fond of pigs. Dogs look up to us. Cats look down. Pigs treat us as equals. So let's get started. We'll have Professor Naka, who's going to talk to us about the history of transplant surgery. Thank you.
Roger, may I interject?
Yes.
At this moment?
Of course.
The sound that I'm hearing is rather very, it's not high, it's very low. So is it possible for them to increase the volume?
We'll work on that.
Thank you.
We'll work on that. Thanks for letting us know. Let's have Professor Naka here, and thank you so much.
Can you bring a slide to the first one, please? While doing so, I just want to correct some statement made by Dr. Hato. Can you bring the slide to the first one, please? Dr. Hato said that the Colombia is the NYP is like the largest transplant center. In terms of the heart transplant number, is not actually largest like last year. But what we say, like heart replacement therapy, which include the sort of artificial heart, we've done, like including a pediatric one, is probably almost maybe like close to 170 or 180 heart replacement therapy last year. So that is the largest number. And also, like Colombia side, we started a transplant in 1977. And we've done almost close to the 3,000 transplants over those years, which is also the largest number all over the world. So I was trained. I was trained by there, and then here's the I cannot see well. Here's the inception of the heart transplant by the. You can take it in your hand. Okay. So this is done by the Christian Bernard in the South Africa, the first transplant. This was actually, the transplant was a DCD, which is the donation after cardiac disease, which is totally different from the current, the regular heart transplant, which is the donation after the brain death. So this is the DCD, first DCD. And then, but that, so the previous one is also the Life, and the next one is like another Life magazine, like a front page, which says the heart transplant did not do well. So they could put like this. And then it's also another activity was a total artificial heart. This person was a very famous person, received the total artificial heart. It's called the Jarvik 7. It's actually Dr. Jarvik later created another Jarvik heart, which is totally different. And he created the new Jarvik heart, which is a left ventricular assist device, in the New York City, in the building. You know, it's like he's not doing anymore, but it's amazing. And then the new immunosuppressive drug, cyclosporin, came out. And that improved the outcome that would be explained by Dr. Majura. And then this is the baby Faye, right? Unfortunately, she lived only 21 days. The baboon, which is the concordant, like a concordant means, similar to human, compared with a pig to human or dog to human. It's concordant transplant, but she suffered the graft rejection and died. And then this is the first generations of the left ventricular assist device. can you tell like how big the device is? I was able to put the device inside the body, like the abdomen. And the next generation is like it's called HeartMate 2. It's much smaller, right? And now the current generation is HeartMate 3. It's much smaller. So can you run the video, please? So here's one of the heart failure patients, and I put in a HeartMate 3 as the study. And then he's now playing golf with the device inside his body. Okay, so this is the current survival. So only the 2 years survival is shown here, and dashed line is actually heart transplant 2 years survival. So the highest survival is actually HeartMate 3 momentum trial cap protocol. So the man-made device can achieve, in terms of survival, but can achieve the similar survival up to 2 years compared with heart transplant. That is the technological, big time advancement. And then now that this is also another technology is the genetically manipulated and a pig heart put into this person. So the heart transplant, you see the heart transplant kind of stagnant over the last 20 years. But recently, we do accept a hepatitis C positive donor, even near viremia, because we can treat hepatitis well. And then opioid epidemic, so that there are many people unfortunately die from the opioid overdose. And then technological advances in heart procurement, meaning you have to take a heart out from the donor and put it into the recipient. So that this transfer need to be supported by something. A standard practice is just stop the heart with special solutions, which called the cardiopressure, and then put it into the ice, and then cold storage, and put it into the recipient body and warm up and start. But now it's a little bit different. And then I said that the donation after cardiac disease donor, which is a first transplant done by the Christian Barnard, was like a DCD, but a long time we haven't done. Recently we started doing so mid 2010 that we started doing. Not I haven't done yet, but all over the world, the surgeons and the scientists were doing this kind of heart from cardiac death patients. And then we do last year, total number of heart transplants is over 3,800. So it's almost twice of 20 years ago. So this is I'm not advertising this device. Don't be get wrong, but so this device, and take a heart out from the donor, either DCD or DVD, and put into this device, and then warm up with the donor blood, and then just the beating, and we transfer this heart to the recipient hospital, and then we can put it into the recipient. So it's heart is being oxygenated and kept very well. So this is another advancement. So maybe David? Yeah.
Thank you. Make sure that I had it right, yeah. So this is an awful lot of territory to cover in one talk that we're talking about here. The intention here is that we have these surgical advancements that are happening, but in the background there's an awful lot of science. And this timeline here is really looking at all of the Nobel Prizes, where are we? All the Nobel Prizes that have been awarded in immunology since 1901 all the way moving forward. Each and every one of these Nobel advancements were critical in us understanding the immune system so that we could do successful transplantations. And I put this on the background of the change in survival of people who have had a heart transplant and contrast that with the advancements in immunology. And so early on in 1967, when we did the first transplant, they were using things like radiation, steroids like prednisone, some chemotherapy to really suppress the immune system. But it didn't work very well. People did not live very long. Additional agents were introduced, like azathioprine. But it wasn't until the introduction of cyclosporin that there were real changes. And you can see that the survival curve really picked up. And then little by little, we've had addition of other agents, refinements, and different characteristics that have allowed patients to live even longer. And so currently, the median survival of a person receiving a transplant is 14 years, which is quite good in comparison to these people that would need the transplant. They would be dying in, say, 6 months, 2 months, even sometimes shorter. The immune system is extremely complex, and we continually learn more about it, but we still have a lot to learn. And I think, with COVID, people have been getting a better sense of the immune system just in the lay press. This is a very simplistic representation of the immune system, thinking about the innate immunity. That's the immune response that's immediate. It's nonspecific. It attacks organisms without having a real direct relationship to that organism. And then we have our adaptive immune response, which are the T cells and the B cells. The B cells produce the antibodies that can attack organisms. The T cells can get activated to specifically attack a particular organism. In humans, all of our cells are coded in something called MHC molecules. They're derived from the HLA genes, human leukocyte antigens. And it's one of the most diverse molecules in our body, and it's unique to each and every one of us. And it's the main impediment to successful transplantation, because we have to keep our own immune system from recognizing the MHC molecules of someone else's organ, whether it be a kidney transplant, a heart transplant, or whatever it might be. And so most of our efforts are directed towards inhibiting the interaction of our immune cells, this pointer's not all that great, with these molecules right here. So we do that by targeting lots of different pathways in the immune system. This is just a number of them here. We use drugs like cyclosporin to interact with the receptors of the T cells. That goes to the DNA being produced, the various proteins, and so we inhibit that interaction with steroids. We inhibit downstream signaling with drugs like sirolimus and everolimus, and arrest the cell cycle with drugs like mycophenolate. We also interrupt the interaction of so-called antigen-presenting cells with T cells, all of which together can help us to abrogate the immune cell response. So how is this different with pigs? This is obviously a big thing. We're talking about taking another organism. We're both mammals, but there's a lot of difference between pigs and humans. Pigs do not have the human leukocyte antigen, which is the major barrier in human-to-human transplant, but they have other proteins that can be problematic. And so CRISPR really changed the game. So CRISPR, as many of you know, was developed over the last couple of decades. Recent Nobel Prize in 2020 was to the two investigators that really popularized the concept. That allows us to essentially eliminate particular genes, and if we so desire, to insert other genes. Obviously, a lot of really interesting questions ethically and otherwise about this practice, but it's something that we will gradually confront as time goes by. So what research we're able to do is we identified 3 carbohydrate antigens that humans particularly have responses to and just basically got rid of them in these pig allografts. Complement is a complex protein collection that destroys invading cells. They insert these little cores, they're called membrane attacks complexes, right into cells. It makes the cells basically spill all their guts into the outside of the cytoplasm. They have inserted genes to basically trick human complement from not interacting with the pig cells. In addition, it was recognized that humans interacting with pigs will cause thrombosis or clotting of the blood cells in the pig graft, so there were genes inserted to regulate human coagulation. In addition, it was recognized that the pigs' hearts would continue to grow, become stiff, and not work very well, so they knocked out or eliminated the gene related to growth hormone. In addition, targeted other inflammatory pathways. So essentially, with this particular pig model that's in place, they changed 10 genes to try to make an organ that the human would not reject. In addition, though, it's still a very different species being transplanted into a human. And as a result, there's still an awful lot of immunosuppression that has to be taken by the recipient in this case. And this middle panel here is looking at all the different areas that these recipients would be immunosuppressed. So active B-cell depletion, T-cell depletion, complement deactivation, co-stimulatory blockade. It's a lot. With human-to-human transplants, we use perhaps 3 different targets of immunosuppression, usually just 2. But once again, we're limited in terms of supply. This is an attempt to solve that problem by creating more supply with a pig organ that's been modified to allow for the transplant to occur. Dr. Naka, do you want to take over now?
So I'm going to wrap up a little bit. So so this is recent heart transplantation in Maryland. The discordant, meaning huge difference in terms of compared with the baboon to human. So it's called a discordant. So why he was chosen, this patient? Actually, we don't know. It says in the newspaper a patient was not compliant and a lot of irregular heartbeat, and then he was not the good candidate for the regular human-to-human transplant, but still not compelling for me why he took this way. There's something hidden, reason that they have not released yet. And why pig? So the pig is especially the heart is the shape of the heart is similar to human heart. So that's easy. And also the pig is actually farmed, and there's a lot of science in farming the pig. So doing a lot of genetic modifications, it has been already there. That's why the pig is the good animal, not dog, and the dog is not big enough. Chimpanzee or baboon, those are not. The number of those animals is not a lot. So a pig is probably those variety reason that the pig was chosen. Immunologically challenging, as Dr. Majua said that, and then also the pig has a virus in their gene, and then the retrovirus. So that may be transmitted to the human, and then later on human to human, maybe. So it's recently a COVID-19, that's the zoologic infection, right? From the maybe bat, and then infected the human, and then the widespread. So it's a kind of a very concerning area that we have to control well. And then the technical issue is probably, in terms of surgical technical issues, it's okay, we can do it. And then we don't know how he's doing. We haven't had. He died, so probably I assume he's doing fine. And the FDA gave the compassionate use. It's not like a trial. It's not a humanitarian device exemption. It's just compassionate. But we would like to do eventually, probably a few or several, the company try to create genetically modify the pig, and then they may come to NYP or for us to try those xenotransplant. And the future plan of the xenotransplant, still we don't know. Another way to cure the heart failure is a kind of a reviving heart. We've done, but although it's not a strong or powerful as the heart transplant or the mechanical circulatory support, but using mechanical circulatory support, heart may recover the functions, which is about 2%. So it's not a huge number. And the cell transplant or cell seed, which has been tried, but not yet. And then gene therapy, I haven't seen the great success yet. But human imagined, and that may be eventually materialized. So we'll see how they do. And then creating a heart on a decellularized scaffold. This is a kind of SF, because you took the pig heart and then do some enzyme and then kill all the live cells and then just just get in a scaffold and depopulate in the human cells and make a new heart. It was done in a rat, and that works probably 1% of the the full working mode. So it's still very early. So maybe like a future of the treatment of end-stage heart failure is maybe the combination of all of them and tailor down to each patient. Can you run the movie? So this is like a movie from the Star Trek. And this young guy is actually the young Jean-Luc Picard. And he showed the artificial heart. That's called a solid deuterium heart. So like, can you go to the? So Jean-Luc Picard is actually the recipient of a total artificial heart. Thank you very much.
Thank you, Professor Naka. That was a fascinating overview, and David, thank you so much. It's fascinating. So maybe before we go to Professor Hussain and talk about some of the ethical issues, is there a medical question? Anybody has a particular medical question for Professor Moore?
Yeah, quick question. Would it be possible at some point to put a mechanical device that would keep the heart going, take the sickly heart that you just removed, implant it somewhere else in the abdominal cavity and let it heal somehow? Is there something that I had heard about that, but
Let me just, maybe people probably didn't hear that. The question was, can you take a sick heart, kind of like we do with cranioplasties, put it into the belly until it heals up, and then put it back as a functional heart into the same, basically the same body, the same human being?
I'll say the way that we do that currently is with the LVAD. And so what we do is we implant the LVAD, and then we monitor for recovery. And we have protocols for explanting the LVAD after the heart has recovered, and we put the patients on therapy to help recover their native heart function. So around the country, of people who receive this assist device, the left ventricular assist device, who have advanced heart failure, recovery rates are perhaps between 5 to 15%, depending on the center. Not many people you can recover that way. But as far as something more advanced that you're saying, there's nothing like that in production yet. I don't know, Dr. Naka.
Well, that's a fascinating idea, and I've done the rat and the mice heart transplant into the abdominal space. It's called the like a heterotropic heart transplant, and then those heart going through the disused atrophy because they are not moving, they are not like ejecting well. So I'm not sure that idea, but idea of using a left ventricular assist device and then kind of less the broken heart, and they may go through the reverse remodeling and then get better. So some work, not full work, but some work, but not zero work, may be good. So somebody would do it.
I think it was a great question. Thank you so much. Now we'll move on. As you can tell, I mean, we talked about the pig heart transplant, incredibly exciting, but also very, very, I guess, controversial and concerning. If you mentioned about the risk of infection. Pigs have certain viruses that can be transmitted then via the transplant to human beings. Tremendous implications, obviously, going forward. Now, Professor Hussain, he's calling in from Toledo, Ohio. Thank you so much. Can you hear us now better? We can hear you, though.
Yes, I can.
Yeah, that's great. So you're a retired cardiovascular surgeon. You're also professor of the humanities at the University of Toledo in Ohio. And, I know you have a column that you publish every 2 weeks, including something that you published recently about the ethical issues related to pig heart and xenotransplant. What are your thoughts?
Well, first of all, thank you so much. I am really grateful to Anne for organizing this very important symposium. And as has been mentioned Valentine's Day. And I want to thank you, Roger, for including me in this program. I will discuss ethical and religious aspects of pig heart transplantation. We human beings have had an intimate relationship with animal kingdom. Domesticated animals have helped us tame the environment and make significant advances in agriculture. Some societies depend heavily on the use of animals for food, clothing, and shelter, while some societies pay considerable attention and even reverence to life-sustaining animals. The society at large has been mostly oblivious to the welfare of animals. We have, thank goodness, come to realization that animals also have rights. A survey of the literature about animal rights, however, leaves one bewildered and confused. I must hasten to add that this confusion and bewilderment has nothing to do with my advancing age. People tend to have extreme positions on the subject. That makes it difficult to find a reasonable middle ground. At one end of the spectrum are those who are totally against using animals for human benefits. On the other hand, there are those who believe in animals were created for the sole purpose of serving human beings. The ones in the middle allow animals to be used for the benefit of human beings, but with some caveats. A great majority of us agree that cruelty to animals is not acceptable. We humans have to be humane to animals. Even in the slaughterhouses, compassion has to be prime consideration. It may sound contradictory and oxymoronic that one shows compassion towards an animal that will soon become food for our consumption. Compassion towards animals demands that we maintain that principle in mind all the time. Much of the research in biologic and pharmaceutical sciences depends on animal experimentation. Is it possible? And the question begs for an answer. To do this science without using animals? Well, there are people who would answer this question with an emphatic yes. But for the scientific community, the answer is no, we cannot. Animals give us an opportunity to learn about how things work in human beings. Most of the progress in medical sciences in the past century has been in part due to animals. I personally do not subscribe to the concept that man has dominion over animals as mentioned in some scriptures. Dominion concept grants a man total control over animals. Missing in this concept is the compassion. I would accept dominion over animals only when welfare and compassion and humility towards animals is an integral subtext to the absolute control. It is in this context that we can focus on the use of pig heart to replace a failing human heart. Dr. Znaka and Dr. Major discuss rather eloquently the pathology of end-stage heart disease and the immunological barriers that nature has placed between human beings and the animal kingdom. Over the decades, we have learned how to successfully cross these immunologic Rubicons that separate human beings from animals. Since the first pig-to-human transplant done in Baltimore about a month ago, there have been quite a lively conversation on the internet, not only about the feasibility of using a pig heart, but also the appropriateness of such a procedure. Ethical, philosophical, and religious landmines abound. Let us keep some statistics in mind, and it has been mentioned in the previous presentations. So let us keep those statistics in mind as the backdrop of this discussion. At any time, according to my reading, there are 50,000 patients on the waiting list for heart transplant. Only 2,000 receive the heart. At one time, it was felt that an artificial heart would fill the yawning gap between the supply and demand. But the artificial hearts did not pan out as expected. They are now used as ventricular assist devices, etc., as a bridge towards a heart transplant. If pig hearts are successful in the long run, they would give a much-needed lease on life to thousands of patients who have run out of all available options. All major religions emphasize the sanctity of life. Both Judaism and Islam place a very high premium on human life. These religions say, and here I am paraphrasing the original text from the Hebrew Bible and the Quran, if someone slays an innocent person, it is as if he has slayed the entire mankind. And if someone saves a human life, it is akin to saving the entire mankind. It is extremely profound what the scriptures, at least the Hebrew Bible and the Quran, says. Let us see how Judaism and Islam deal with pigs. Both religions have a clear-cut and unambiguous injunction against consumption of pork. Pig flesh is categorized with other forbidden substances such as blood and dead animals. To this day, most Jews and almost all Muslims avoid the consumption of pork. The Hebrew Bible and the Quran have similar dietary restrictions. But these religions also make an exception, a fundamental and extremely important exception. And that is, in case of starvation, where the life hangs in balance, pork can be eaten. Some Islamic scholars maintain that the Quran has prohibited the eating of pork flesh and has not banned different parts of pig. Hence, to them, in their mind, to implanting a pig's heart into a human chest does not violate religious dictates. In Judaism, the principle of pikuash nefesh, that literally means watching over a soul, stipulates that the preservation of life overrides any other religious rule. In practical terms, the injunction against idolatry, murder, and forbidden sex can be violated to save a life. This is a wide spectrum of exceptions that can be used to save a life. It appears that other major religions also accept the concept that saving a life overrides certain religious principles. Most Muslim religious scholars agree by granting, most Muslim religious scholars agree that those exceptions granted by Quran from consuming pork, just as the Jewish exceptions justify the use of pig heart for human beings. But there are others who would totally reject pig heart transplant. In circuitous arguments that are very much reminiscent of the story of Liza and Henry and a hole in the bucket, it is a never-ending argument. It is not unlike the debate among the medieval religious scholars where they discussed ad nauseum as to how many angels can dance on the head of a pin or at the point of a needle. History is replete with incidents of such spurious and redundant points of contention. Maurice Maeterlinck, the Belgian playwright and a 1911 Nobel laureate in literature, had said that at every crossroad on the path that leads to the future, tradition has placed 10,000 men to guard the past. We need to get past the proverbial 10,000 men of Maeterlinck and to make advances in science. Starvation and end-stage heart disease fall in the same category. Here, in both these since his life is at stake. The Jewish and Muslim scriptures make the exception that a starving person can consume forbidden food to stave off death. I think we can apply the same principle to a person dying of end-stage heart disease. I'm sure instead of counting the number of angels dancing on the head of a pin, angels will instead dance on the heart of a pig if it saves a human life. Religions, to be relevant in the lives of their believers, must be flexible. I consider religion to be dynamic institutions that, while maintaining the core values and principles, lend themselves to be interpreted according to the prevailing times. And I thank you.
Professor Hussain, that was a profound insight into the ethical considerations. Thank you so much. And we'll move on, and we'll have actually, we're doing this for our patients, not our maybe, but patients who have end-stage heart disease. The 48,000 who are not going to, or the 4,800 are not going to get the heart based on the numbers that he just mentioned. So it's an incredibly high number. And it gives me great pleasure that we actually have a patient tonight here who's going to talk to us about his experiences over the last 33 years with a heart transplant, heart-lung transplant. Can we get Mr. Silver in? Is he going to be on video? So we'll have him tell us his story and then sit in the front and hopefully have a nice discussion. In the meantime, any questions? Any comments? Yes, please.
Other organs being transplanted from, what else is going on in the world of animal transplant? I'm not familiar with anything other than this pig heart experiment. Kidneys, they abound. There are enough cadaver kidneys around. But
there I am.
What else is happening?
Oh, yeah.
We'll come back to the question.
We'll come back. Okay. So, Mr. Silver, correct?
Yes, sir.
Thank you so much for calling in. My name is Roger Hartle. I'm moderating the session tonight. Did you watch the rest of the presentation?
I did. It was wonderful.
Thank you so much for being present tonight and for sharing your story with us. And I mentioned in the beginning that you had surgery for the transplant, for the heart-lung transplant 33 years ago. Do you want to tell us a little bit about how this came about and what your experiences were over the last years?
Of course. So I was born with cystic fibrosis. It's a genetic disorder. 1 in 4 carriers. And what part of it is that my body, the salt membranes prevent mucus from transporting. So eventually people with cystic fibrosis, their lungs fill up with mucus, they lose lung tissue, and they die. Their symptoms resemble a lot of pneumonia. They also have, some of us have mucus in our intestines so that we don't digest. So I'd say a good 70% of us have a very low body fat, and it's very hard for us to gain weight. In addition, many of us get diabetes as we get older in life. And I qualify in all 3 of those. I was at a terminal stage when I was 32, in that my lung capacity was down to 59%. Couldn't go, in my last 6 months, I couldn't go more than 2 minutes without coughing and spitting out mucus. And so I got on the list. I was on oxygen. It was important to stay healthy at the time. So I was still going to the gym on oxygen and bench pressing and stuff because, I mean, they could save your body. They could save your lungs, but if your body is no good, what's the point? Anyhow, I had a very good recovery because I was only the 3rd person they had done with cystic fibrosis. I was number 64 at Stanford. There was not a lot of people to show me what to do. They were very cautious. I was very cautious. It took 6 months for them to release me from there. And after a year, once I had gotten off of the high doses of prednisone my brain actually went back to normal because prednisone can affect your level of depression and things like that. After that, my activity increased, my quality of life increased. I was able to actually scuba dive, which had always been on my bucket list, but you can't do that when part of your lungs are blocked with oxygen because they were just exploding. I was able to snorkel, I was able to travel. Life became very good. I have to be very proactive in taking care of my health. I think it's easier for people who have an underlying condition that they grow up with. I mean, I was taking like 40 pills a day at the time that I had the transplant to continue on a strong regimen, as opposed to, I believe, the gentleman who got the pig heart. They thought that he could not commit to the regimen and he wouldn't be a good client for it. It's a hard road, but like I said, I've been here almost 33 years out of the 66 years of my life on this new heart and lungs. It does come with something new happening every year, every two. But of course, once you're over 60, everybody knows you hear something new anyhow. So if I can answer any questions, I'd love to.
You know, that's a quite fascinating story, and I'm just wondering, maybe walk us through it psychologically. How did that feel? Do you remember 33 years ago, as you're getting sicker, and you know you were only the third patient at Stanford to receive the double transplant? Is that correct?
It was 2 lungs and a heart.
And how do you make that decision? Is that a decision that you made for yourself or with your family, with your loved ones, that you wanted to go that route, or there was absolutely no other choice? How does that happen?
It's a combination of those. When you have cystic fibrosis compared to most people who get transplants, theirs comes on suddenly. With cystic fibrosis, every day you're getting worse. So my lung capacity was diminishing the whole time. I reached a point where I was on oxygen for a year and a half, 2 years. I still went to the gym. I would go on oxygen. I would go off oxygen. But there's no prognosis that suddenly you're going to get better. It's just slowly dying. So I discussed it with my loved one at the time, and it seemed like the only alternative. It had some success. As far as dying goes, most people with cystic fibrosis accept that they're going to die by the time they're an adult. Growing up, I always wanted to make it to my 20th birthday. I always wanted to make it to get married. I never thought I'd make it to the year 2000. So you never plan that much in advance. But things happened. I signed up. My doctor happened to go to medical school, be the roommate of the doctor who was assigning spots at Stanford, which was very convenient. So I went up there, I got interviewed, was actually on the list the next day. Now, in terms of the psychological reactions, I didn't know that I would have reactions, but they gave me prednisone at high doses. I believe it was 125 milligrams to start, down to 60, down to 30. I found personally that anything over 15 milligrams affects my brain. A small percentage of the patients get really depressed from prednisone. I took the Beck Depression Scale. Out of a possible score of 43, which is the worst, I got a 42. I honestly, after my transplant, I'm talking about from the medicine, I didn't care if I lived or I died. Nothing could make me smile. Nothing would make me happy. I could just lie in bed and hope that time passed. I truly, and I was a psych major in college, I truly understood the idea of what depression is and how chemicals actually affect the way you think. As I got off the chemicals and got below 15 and 10, I was better. But the things that affected me as I was on the high doses was I had never planned for a future. I think that's native to people my age who grew up with cystic fibrosis. Prognosis is much better now. I never had to worry about my future. I never had to think ahead. All of a sudden, I did. And that was a major source of stress and trauma. At the time, the doctors were like, "You're healthy. What's your problem? What are you worried about?" Because they were used to dealing with the symptoms. They were not used to dealing with the mental aspects. Fortunately, they put me in touch with a really good psychiatrist therapist who helped me through that. Years later, I founded a transplant group in San Diego for everybody who went through a transplant. We assigned a mentor program so that everybody going through that would have mental support from somebody who went through it, because that's an important part of the recovery.
Fascinating. Just to complete your story, and then you had another transplant, a kidney transplant, because of the side effects of the immunosuppressants. Is that correct?
Cyclosporin tears through kidneys. There's no two ways about it. But until they had something that was better, I had to wait. My kidney function had finally gone down to stage 2 and dropping, and I had a really good nephrologist, and he was able to switch me to sirolimus, which they had just started using. I had originally been on cyclosporin, what else that, I can't think of the other drug, and prednisone, high dose. Well, I was still taking 12 milligrams of prednisone, and I was able to switch. And that prolonged me pretty close to the level I was at until I qualified for the kidney transplant. I qualified 4 years later, but of course the wait for a kidney transplant is very, very long. I was scheduled to find out about dialysis about 2 weeks later at the time that I got called for my transplant. So I was very fortunate, because patients who have a transplant don't do really well on dialysis.
Amazing story. Maybe we'll move to the front and we'll start the discussion. We're kind of in the discussion already. If you don't mind, we'll take a seat in the front so you can actually see our front. And we still have Professor Hussein there, correct? Is he still with us?
Yes, I'm here.
Yeah, good. So maybe we'll get started with Mr. Silver. I was just, when I was listening to his story, when somebody like Mr. Silver was incredibly courageous and really somebody I think we all admire, it's not only the surgery, then all the psychological effects, right, later on, and because of the medication, the depression that somebody potentially goes through, of course. But Mr. Silver, if you see the news now about the pig heart, the pig transplant, what goes through your mind? Is that something that you have a unique insight into the problem? What are your thoughts about that?
Well, when they were developing the lung transplants and I went up to Stanford, they were working on dogs. And granted, that wasn't for a human to human thing. That was for human to human. In terms of the pig thing, you have to start somewhere. There's an incredible need for organs. This man was desperate. That's going to be the kind of person who will try it. If it prolongs their life for 20 days, and you ask that person, he's going to tell you those 20 days were worth it. I have no doubt. Where this goes in the future, if they become interchangeable, it's a miracle.
Help me understand again the mechanical implants that you're working on. Are they potentially an alternative to something like a allograft heart transplant or a pig heart, or as Professor Hussein mentioned, they're really more assist devices? I think that would. Can you clarify that?
So the assist device, as I showed, the current technology can prolong those advanced heart failure patient life, very similar to the heart transplant in terms of just survival, but they're still like tethered to the like a drive line. They have to carry the batteries, which is still not very small. They have to carry the controller. So it's not same as the pacemaker. The pacemaker, once you get the pacemaker, you can forget about it. But an assist device, with current technology, you cannot forget.
But the assist device is inside your chest.
That's correct.
So, and it takes over the full function of the heart?
It's actually not full function. So you may be reminded that it said assist device. It's not called replacement device. So we assist the left ventricle, which is only one chamber of the heart. The total artificial heart is totally depressed the heart, but that has to be, a 23rd century rocket science in order to have it, and then the afterthought. So at this moment, is assist device is probably best device, and still industry is working on it, but it's gonna be very long way to have the a much smarter assist device and totally implantable with maybe a nuclear energy battery inside your body or something like that.
So a real mechanical alternative is not going to the battery went out. Yeah. Can you hear me? Yeah. So the alternative is really an allograft transplant or potentially an animal in the foreseeable future.
I don't know. Well, all those technology is also very expensive, and then the most expensive technology among what you said is actually xenotransplant. Can you imagine how much this xenotransplant costs? $500,000. Just for the pig. Yeah. So it's in terms of assist device is also expensive. The human heart, if we use the transportation device, which is also very expensive. So everything is expensive. You may say the human life may be heavier than the earth, but it's very expensive. And then we may be able to use the medical expenditure for the better way. I'm not sure this is the best way.
Yeah, I think the intention, of course, is to reduce costs.
There is this is Amjad Hussain. This question comes up in the general context of healthcare cost. Heart transplantation is expensive, and there are many other procedures which are expensive. And one wonders if the country, affluent country like the US, can it afford to spend as much money on heart transplantation or other procedures which heart transplantation have been successful, bone marrow transplants in some diseases have not panned out. So that's always a question. When at our M&M conference, I am the only one faculty member who asks the resident when they present a morbidity or mortality to see how much did it cost to take care of this patient. And they are clueless as to how much it costs to take care of a patient. I am not suggesting that there should be a quota system or rationing, but I think we do rationing inadvertently in healthcare. It is there. We don't call it. So these are also questions which need to be addressed when we make new discoveries and find new ways to take care of certain patients. This is more ethical, really, than anything else. So I just throw it out for your consideration.
By the way, any comments, questions from the audience or online? Yes.
Yeah, you've got 3,800 human heart transplants a year? I'd be curious, what's the limiting step on that? Is it the availability of good hearts? Is it the cost of doing the operation? In other words, I'm not the expert here, but just speaking, like an engineer, I'm surprised there are only 3,800 good hearts. Is it the transportation system? You know where I'm getting at, so please elaborate.
Maybe give us the numbers again. How many patients are waiting for a heart, and how many hearts are there?
The total number, it's a constant process of people coming in to being listed for transplant and people that are getting transplanted. At any given year, probably about 15% of people on the heart transplant list die while waiting for a heart transplant. But those are people that are listed. And then you have the larger denominator, which is people who, if they were candidates otherwise for a heart transplant, could still get it. Because both with lung, heart, kidney, we don't want to do these procedures on people who have so much health problems otherwise that even if they got the organ, that they would still not do well. We're looking to give people long-term, high-quality life, just like Sheldon got. 33 years, that's amazing. Right, but that's what we're looking for, is to give people high-quality life for a long period of time.
Pardon me for interrupting. Please speak in the mic so we can hear it.
So sorry about that. I'll bring it a little bit closer. It's a different mic. As far as the organ numbers, you make a great point. You'd think, my God, we live in a country of 350 million people. You'd think we'd be able to garnish more than 3,500 hearts a year, right? The part of the problem is, one is organ donation is in and of itself a problem, having enough people who are signing up for being organ donors. And when people die or become brain dead and they're not organ donors, that their family then consents for them to become an organ donor. The primary process for us getting hearts, or any organ for that matter, for the most part at least functioning organs, has been through people who have been declared brain dead. So Dr. Naka touched on this earlier, but they have either had some sort of trauma to their head. The opioid epidemic, unfortunately, is a source of a lot of organs these days because people get oxygen deficiency to their brain and they become brain dead. Then in a very controlled fashion, we're able to go and get those organs. The way that most people die, though, is not through brain death. They're dying for other reasons. And there's recently been, and Dr. Naka talked about this, deceased circulatory death, meaning that we think the person, they're in the process of dying, they're consented for organs, and the process is one where they're actually taken to the OR, taken off the ventilator, allowed to die. There's a process of about a standoff period of around, it depends on the situation, 5 to 15 minutes. They're declared dead, and then the process of organ harvesting happens. But that's only recently been revived, and obviously there's a lot of ethical issues related to that as well. You can imagine that's a very tricky issue that still needs to be worked out. The advent of the new machines for transporting organs that Dr. Naka brought about may also allow us to recover a lot of organs and see how they're doing on this really amazing machine that will reperfuse the heart and get it beating. We can look at it, see if it's working. That's also done with kidneys and also lungs. So there's a lot of movement right now in the technology. This whole conversation is about the progression of the technology that will probably change this. But there's always costs and ethical issues that come along with that.
I know. I'm acquainted with a CEO of a large company who has a heart transplant. And I think for him, cost was no object. How does it work with, regular folks like most of us sitting in this room if we happen to medically qualify and need one? How does it get paid for? I think there's a lifetime cap on my ridiculous healthcare system of $100,000 or something like that.
Yeah, it's a big question. We are right now.
May I, excuse me, please repeat the question?
I was just saying, who's gonna pay for all this? I know somebody that was able to do this, and I don't even know the economics, but most of us in this room, have health care plans that cap out at $100,000, and it's hard to come up with the extra $400,000.
Yeah, so the question, just to repeat it, is how is transplant, generally speaking, funded? Most people who have insurance, usually that's not the problem that we run across. More problematically in the U.S. is that there are great disparities in terms of actual access to insurance at all. Or people, like you point out, might be underinsured. So for instance, right now, we are trying to expand access in Brooklyn and Queens, a great area of economic inadequacy. And so one of our charters is to try to figure out how to make access better. But that honestly should expand across the continuum of healthcare. You know, if we're talking about just taking care of people at their sickest, well, we should also be talking about taking care of people before they get sick. But yes, transplant, if you have some form of insurance, usually we're able to work that out.
Medicare pays for it.
Yeah, Medicare pays for it. So if you're a Medicare recipient, usually we're able to. But it's, you know, it's a lifelong process, yes.
Philip has a question.
Yeah, I have a question. Animal to human transplants clearly have a lot of less of the logistical and cost problems that you have with a human to human transplant. Other than heart transplants, are there any successful animal to human transplants besides the heart transplants which you discussed today?
So actually, the recently it's interesting experiments. The pig, the genetically modified pig kidney, was transplanted to the brain dead person to see how the kidney works. So it's like expanding to the other organs, and then in the history there are many like non-human primate organs, mainly kidney to human, but some of the very cavalier surgeons did their discordant pig to human heart transplant, and then the recipient died in the OR or something like that. So, you know, there has been a history. The now is those cavalier transplant is becoming more acceptable options, although still not yet.
Dr. Moore has a question.
A question for Mr. Silver, if he's still there. Oh. All right.
Well, let me maybe a provocative kind of scenario. So there he is. Okay, Mr. Silver, did you?
Mr. Silver, I have a quick question, if you allow me.
Of course.
You've been the recipient of the worst thing that can happen to a human being with your initial disease process, and probably the best thing that can happen when other humans come and use transplants and organs from 3 different people, or at least 2 different people, to support you through your life. How has that changed your view on humanity?
That's a hard one. I mean, I've always been a humanist, so I've always looked at the better side of humanity. I'm grateful to be alive, and I have worked to get people to donate organs. I know I had inspired 2 people right after my transplant to sign up to donate their organs. I think there are a lot of good people who say, you know, when I die, if somebody else can use it, it's a gift for them, and I'm proud to do it. And there are some people who are just like, it's not for me. I respect both of them. Does that answer your question, or not really?
It does definitely, because obviously you took your story and brought it to a level of helping other people. But for you yourself, when you're alone at home and you're like going, oh my gosh, I had so much bad luck because I got cystic fibrosis. And then on the other hand, you can say, well, I had such good luck because I had such successful care. How does that balance yourself? Is that a source of inspiration, a source of depression?
All right, so I'm going to share my true feelings, and I hope they're okay. Growing up with cystic fibrosis, I just accepted it because I was diagnosed at 6. I always thought of myself as normal like everybody else, even though I wasn't. I went to grad school, and I wasn't healthy enough to work. But I still thought of myself as just like everybody else, just unfortunate. I would get on the pity pot once in a while, and my wife would help me off it. I would only stay there for an hour at the most at the time. I had my transplant, and I'm ashamed to admit that a lot of the time I just take it for granted now. But I do appreciate the gift. And when I come in contact, one of my best friends still has cystic fibrosis and others, I have a tremendous amount of empathy because I know exactly what they're feeling, and I do my best to help them. But, you know, I do take it for granted a lot of the time.
Yeah. That's probably the best answer for success then.
That's exactly what I was going to say. I mean, the fact that you can take it for granted means that it was successful. Our job is to liberate people to live. That's what we're trying to do, not to confine them to an illness state. So I'm glad to hear you say that, quite frankly.
Thank you.
I think we got to slowly finish up, but we have another question. Yes, comment?
So it has been proven, times and times again that small economic nudges can have a big effect. So I'd like to ask, what are the opinions on making organ donations perhaps an option that you need to opt out of instead of opt in? Would that help save lives?
Yeah. In many countries, that's what it is, right? You have to opt out.
The results have been mixed. I mean, I think even just last week, I don't know why I was reading about this, but in Spain, where they've done that, it didn't have the intention that it had hoped to in terms of increasing organ donations. And the reason is because it goes back to this idea that how people are dying they dying in a way that you can actually get their organs, and the people that are dying, would they be good candidates for organ donation for the types of things that we're trying to get? So, for instance, we might take a heart from somebody who's 50, but that's pushing it. And so in Europe, where, quite frankly, there isn't as big of an opioid epidemic, there's not a lot of gun violence, there's not a lot of car accidents, people are dying at a much older age, and so a lot of the times they're dying at an age where these types of organs, you can't actually use them. You might be able to use skin grafts or cartilage or other sorts of things, but heart becomes a lot harder. Whereas, it'd be interesting to see in a country where, unfortunately, perhaps because of the wide range of economic diversity, however you want to call it, in the U.S., the gun violence, opioids, like maybe opting out actually would work because of the way that people die. But that's also somewhat perverse in a sense. So it gets complicated,
So just a provocative statement real quick. So there's a huge discrepancy. We need more hearts than we get, and mechanical heart is not a good option. The supply of allograft transplant is not really guaranteed. Tissue engineering doesn't work. So are we going to have a situation where we have animal farms at the hospital, pig farms at the hospital, where we're going to have hearts being grown, kidneys, retina, lungs? I mean, seriously, that's what may happen, correct? Or not?
Well, the human beings imagine something. Once you imagine, that may happen. So it may happen, but it will be still a lot of barriers that we have to overcome. Also, one more thing, I want to just correct what you said. It's yes, the heart transplant is very limited numbers. We are doing the ventricular assist device insertions on those who are not waiting for heart transplant. So it's a sort of old people. We still have a kind of age limit for the heart transplant. As David said, that we want to utilize the precious resource to give the maximal benefit, meaning longer survival, enjoying life, blah blah blah. So the people who people who have very limited activity, and we can do heart transplant, but those people may not live long. And then I don't say the old patient not gonna be a heart transplant candidate, but all the people have some other organ issues, and then we do the ventricular assist device on those people who are not much with the heart transplant indications, but we do the assist device to have them more life and then enjoy life with family. That's what we are doing.
So we'll have one last question or comment, and then we'll have Professor Hussein.
I have a question, Roger, if I may ask.
Yes, of course.
This is to Dr. Naka. We know that there is lots of viruses which may be peculiar to certain animals, and they probably would infiltrate or invade the human being after a pig transplant. If I may just give a historic vignette, back in the 60s, Dr. Ben Eisman in the University of Kentucky Medical Center was doing pig liver perfusions. That is, a patient who has an end-stage liver disease, cirrhosis or whatever, they would bring a pig liver from the lab, from the animal lab, and then hook it up to the patient and perfuse. And there was a temporary improvement in terms of the lab results, but it did not pan out. Later on, we found out that there is a host of things which pigs and other animals have, and some of them are peculiar to them. And this is another danger, and that is we might be introducing alien, if I use the word advisedly, alien viruses to the host body. I wonder if, Dr. Naka, you have some comments on that.
Actually, I touched on that issues in the
yes, you did. Yes,
infections, and then some retrovirus also in the pig gene. So that could be introduced to the human body, and that may become like a sort of like a zoonotic infections among humans. So that is still the risk of doing xenotransplant. So we have to be very careful about it.
Right.
I was under the impression that they're having sublists for organ transplants. For instance, if somebody needs a kidney and they're more desperate, there's a list of donors that are less than optimal that they can consider, such as somebody who has CMV or various other factors. Is that not true?
For different organs, there's different lists. For heart, there used to be an alternative. So the question is are there different lists? And so we haven't really talked about the way that listing works. And it's complicated because it's different for every type of organ. But what you're referring to are organs that would have been turned down otherwise, that would have gone to waste. You take them for people who are desperate otherwise. I actually don't know currently in the U.S. what's happening with kidney in that regard. In the U.S., there is no clear alternate list for hearts. There used to be, but that's no longer the case. So people are hesitant to take those because ultimately our outcomes are heavily monitored. And if we underperform, you could be shut down. And so people are very hesitant to take those marginal organs. And yeah.
I don't know if this is working. It is. Is China a big supplier of hearts? According to the Amnesty people, they have a huge number of executions annually. A little bit under 4,000 is what I saw. Are they a supplier? And do they harvest hearts?
So what happens in China is a little challenging to get at. Because of that practice, China is not permitted to be a part of our International Society of Heart and Lung Transplantation, and so they don't participate. But that has been a concern for a long time amongst human rights organizations. But the practices in China are quite opaque. it's very difficult to know exactly what's happening. I don't know. Do you have more information about that?
So the Chinese government control those the donations or supply. There are many rumors about that, but as you can tell, for example, like a COVID pandemic and how many infections in China, you may not get, unfortunately, the real numbers. So in terms of heart transplant, where the heart comes, where the organ comes, you cannot find it out. That's the biggest problem. Yeah.
I think Amjad wanted to add something. Amjad?
No, I don't have any question. Thank you.
I was hoping that you would give a final word of wisdom, since you're the humanist in the room.
Don't look for words of wisdom, but I will just make a comment. One will be probably a friend of mine, a poet friend of mine from Pakistan, after he read my column on the pig heart transplant, he coined a word, and that is, we used to have pig-headed people, but now we're going to have pig-hearted people. So it's a nice combination of having that. My concluding remarks are that, as have been said, we don't know what the future lies for the human heart transplantation. We have made progress over the past, since 1968 or 9, the first heart transplant. We have made tremendous progress. And we also know that we have partially conquered the immunological barrier I mentioned about, that we have crossed those Rubicons. But there is a lot more which still has to come. I don't know what the future lies as to what kind of organs from what source will be available in the long run, whether we will be able to get artificial hearts to the point where they will work for the long time in somebody's chest. We're not there yet. However, the progress is being made. But I also will say that I think, as members of the society, it behooves us to also keep in mind as to how much we spend on what, because economic realities are there. If there is a pie, and if one area gets the bulk of it, then other people go without. So that need to be also in place. I have not found any ethical issues with a cardiac transplant from a pig to the human being, although there are some noises on the periphery which don't like that. But I think it is becoming, the thought has becoming, not the transplant, but the thought is becoming mainstream so far as religious and ethical issues are concerned. So I think there is a lot to be learned, and stay tuned. I think we'll learn a lot in the coming months and years.
Professor Hussain, thank you so much. We'll all be pig-hearted at one point, probably, but hopefully not in the near future. So I want to thank Ann Passer.
But before you conclude, I just want to add one thing from one of our members who's been watching online, and that's Jeannie Wilkie, who's saying, registering as an organ donor is so important. Remind your friends and relatives on Valentine's Day how important it is to check off that box on your license, or whatever state you live, whatever the state requires. But please, it's so important to be a donor. So please check it off.
That's it.
Thank you so much, Ann.
Sheldon, it's been amazing. All of you, thank you. I can't thank you enough for being here. This is one of the most important programs we've ever put on. Sheldon I've known for many, many years. In fact, he came to our last ECAD, and I thank you for doing that. It meant a lot to me, and it means a lot to me for you to be here this evening. So, and take it away, Roger.
And I think it's all your, we have to be thankful. I would have talked about spine all night. So I think
we'll give you a chance another night.
Was much better. I would have talked about back pain. So I think this was much more fascinating. So thank you, Professor Naka and David, and Professor Hussein and Sheldon. Thanks for being part of this, and Anne for really inspiring this.
Thank you to everyone here. Just incredible. Thank you for all of you in our audience tonight and watching online. Please join us on the 28th for lesser-known stories on Black exploration and history. So hope to see you soon, and thank you to everyone tonight. Bye-bye.
I really love that, and I would love to see it.
If you go online, and I'll give you my. Oh, you got my email anyway. Yeah. What's that? It's an exhibition I have at the Goliath Club about photography. Yeah, excellent. I'll send it. Yeah.
My wife and I will definitely come.
Thank you. And that was a great question.
Well, yeah. I'd like to see you professionally.
Of course, yeah.
And the other is...
do you have a card or your name?
Yeah, I do. This is how to get hold of me, and the other is a real pompous bit. Someone showed me to do that.
Oh, wow.
Because this way you can write notes.
Yeah.
You know how you have a card? Who is this person you forget after 2 months or whatever?
That's true, yeah.